we have a couple days ago, and we have a very special case. And I'm not just okay. So many people come in. Hi, Dr. Olisa. More afternoon. Dr. Win, do you ready for share slide? Win, are you ready? Maybe the technical issue. So I have waiting for a while. Oh, many friends from Indonesia. Yeah. So selamat datang, selamat datang everybody. And ni hao for Singapore. Ni hao for Singapore. So we have friends for pediatric nephrologists, and we're waiting for Sunita coming.
Hello, Golf. Hello, everyone. We are here actually all in a group. I will turn
Okay,
on the
Sunita,
video.
because I see your face is panda look. So
This is us. Can you see us?
yes, it's very
Okay.
cute. Cute Sunita new version. So Win, are you ready? Are you ready?
Yes, we are.
Okay. Sunita, please maybe you open the OSEC CBC and then we will conduct. And Dr. Pringle, nice to meet you again.
Hi.
Dr. Jirisit, he is a renal pathologist for gonna disclose and gonna answer the case for us. Sunita, are you ready for open?
Yes, we are. I mean, I think we can do this very informally. Good afternoon to all our friends from the Asia Pacific or OSEA region. I'm very happy that so many of us are able to join this afternoon. And also thanks to Golf and his team for taking the first CPC rounds. So back to you, Golf.
Okay, all right. Thank you, Sunita. She's actually she's chair of ISN OSEA. So Dr. Win, if you're ready, so maybe you introduce yourself and then you present the case. I think people have the protocol, so you just roughly brief the case. Dr. Win actually he is a first year fellow and soon upcoming to second years. When you have to unmute yourself. Actually, his name is not common for Thai people. Normally, Thai have a long name, but he is a very short name. It's Win, just easy to recognize and call him. Win, you unmute yourself, please, and then you start present case.
Sorry, I didn't unmute the microphone. So thank you for your kind introduction, Professor Thalangsak, and good afternoon, everyone. My name is Win Kunwichit from Chulalongkorn University. So today I will guide you through the case of our first regional OC CPC. So this is a case of 58-year-old Thai male living in Bangkok, and the history and physical exam was taken from the patient and the medical record. His chief complaint was bilateral leg edema for 5 months prior to the admission. So 6 months prior to the admission, The patient complained of difficulty in breathing without chest pain, orthopnea, paroxysmal nocturnal dyspnea, palpitation, cough, or edema. His urinations were about 4 to 5 times during daytime without any nocturia. He didn't have any fever nor weight loss, and he was recently diagnosed with hypertension and was prescribed unknown antihypertensive and diuretic medicines from the first hospital. 5 months prior to the admission, he began to notice intermittent pedal edema and eyelid edema in the mornings, along with foamy urine without bloody urination, and the symptoms of difficulty in breathing still persist. 4 months, he developed scrotal edema, and 3 months prior to the admission, he had abdominal distension along with worsened leg edema and dyspnea. He sought medical attention at another hospital, and his blood pressure was as high as 190 over 100 millimeters mercury, and he was prescribed amlodipine 10 milligrams per day and oral furosemide 80 milligrams per day. The lab results from the hospital were shown as the slide and the protocol. And 1 month prior to the admission, the edema progressed without any orthopnea or PND symptoms. His blood pressure was 200 over 100, and he sought medical attention from another hospital, the second hospital, and the lab results were abnormal. So he was referred to our King Chulalongkorn Memorial Hospital for further investigations and diagnosis. For past history, he had no known underlying disease. And personal social history, he had social alcohol consumption. He denied any history of smoking, and he had been drinking energy drinks 12 bottles per day for 15 years consecutively. So this is the pictures of the energy drinks he used. He denied any history of drug allergy or illicit drug use, and denied any herbal medications or over-the-counter drugs. No history of recent vaccination. For family history, his father was diagnosed with hypertension at age of 50, and his mother was diagnosed with diabetes at age of 45. He has no siblings, and he has one son without any remarkable history, and no family history of kidney disease. This is the list of his current medications at admission. For physical examination, he was an adult type male, well cooperative, and his vital signs were shown as above. The blood pressure of right arm, right leg, and left leg here. His BMI was 23 kilogram per meter square. Skin.
We just highlight only positive finding and shortening us.
Okay. Skin was unremarkable. On HENT, he had mildly pale conjunctiva. No palpable lymph node and respiratory systems were unremarkable. Cardiovascular system, his neck vein was 3 centimeters above sternal angle, and his abdomen showed shifting downwards, positive. He had pitting edema, grade 3, both legs, and moderate scrotal swelling. Neurological examination as well as fundoscopy was within normal limit. And here is the basic investigations, CBC chemistry, urinalysis, and quantitative UPCI 24-hour. This is a visualization of his serum creatinine and
We go back a little bit. Go back because some people may not review the protocol before, so you have to just roughly mention on the positive lab.
Okay, so he had serum creatinine of 2.3 milligram per deciliter and BUN of 36, and his
Which
urinalysis.
about how many for micromole?
Sorry, I need to check.
It's about 200 micromole per
200.
liter.
Okay.
200.
Yeah, thank you.
Guys from Malaysia and Singapore, maybe use the different unit from Thailand.
Okay. Thank you, Professor. And his urinalysis show proteinuria 4 plus and blood, and also microscopic hematuria with dysmorphic red blood cell. 50% of the red blood cell were dysmorphic. And his 24-hour urine to protein creatinine index were 12 gram per gram creatinine. His serum albumin was 3.1 gram per deciliter. And he had anemia with hemoglobin level of 9 and MCV of 71 and RDW of 16%.
So you're gonna stop here, or you're gonna review serology a little bit because we have in the protocol.
Okay,
Because
so
in the
should I?
protocol, so should you? Yeah, please. Because we state in the protocol, so you have to highlight the abnormal serology. We don't have to hide. So
Okay, so this is the renal function trend. The creatinine, the first creatinine was 1.3 milligram per deciliter and went up to 1.8 1 month prior to this admission, and at admission it was 2.3 milligram per deciliter. And the green lines depicted the estimate glomerular filtration rate.
from 69 down to 42 within
Yes.
3 months. So almost 30 mil per minute drop. Okay.
Thank you.
Next, please.
Okay, so the after investigations for the anemia, the peripheral blood smear show normochromic normocytic anemia without polychromasia, no nucleated red blood cell, and no rural formation. The white cell and the platelets were normal, and iron study were within normal limit. Cum tests for direct cum test and indirect cum test were negative. Here is the panel of serology. The positive was C3 was below normal, and he had cryoglobulin positive in his serum, and also isolated hepatitis called antibody.
Oh. I think in your protocol, you still have EKG and also
Yes.
flare.
And we performed the serum protein electrophoresis, which show polyclonal gammopathy, and the immunofixation was normal. His kidney ultrasound show normal size of both kidneys, and just diffusely increased parenchymal echogenicity of both kidneys. One simple cyst at left kidney, no hydronephrosis or no stone.
I think
The Doppler,
for other sound, actually in type population, the size range about 8 to 10, so 10.5 to 11 compared to his height. It's quite a little bit larger than usual Thai people.
thank you for pointing out, Professor. For Doppler renal arteries show no normal waveforms and no evidence of renal vein thrombosis nor renal artery stenosis bilaterally. his chest X-ray as shown. He had myocardiomyopathy without any abnormal pulmonary infiltration or opacity.
Okay, so we're gonna stop here, and we disclose so many information, and we don't hide anything. So, who gonna be the first volunteer for list the problem for this guy? I think in this case it's very straight through, but maybe rare. It's straight through. Anybody want to volunteer? If not, so I gonna maybe select from the Zoom.
We have a volunteer here.
Oh, thank you, Sunita.
Hi, good afternoon. I'm Ben, one of the nephro fellow from HKL Malaysia. I will try my best. I think this case is a case of nephrotic syndrome in a 58
Can you introduce yourself before you assess the case and list problem?
Sorry?
Can you introduce yourself?
Oh, hi, I'm Ben here, the nephro trainee from HKL Malaysia under Dr. Sunita. From this case, I think we are dealing with a nephrotic and nephritic syndrome because patient's albumin is low. She's proteinuria and she has nephrosis with high BP as well. The uric FME also has a red blood cell count which shows dysmorphic RBC, most likely a glom injury. So probably based on the history and the physical examination, we do need to entertain a few differential. Number one, of course, staring at is it cryoglobulinemia? Number two, we still have to make sure it's not IgA nephropathy, FSGS, or even MPGN that I'm thinking about.
So any explanation for creeping of serum creatinine within 3 months? You just list only nephrotic and nephritis, and how about creeping of serum creatinine?
I think the renal impairment probably because of the nephrosis itself. But of course, we need to rule out any evidence of thrombosis, which can lead to the AKI. Yeah, then we will have to biopsy to look for the cause.
So, any differential diagnosis for the cause of nephrotic of this case?
Cryoglobulinemia.
The first one and second one and...
Sorry? Cryoglobulinemia.
And any other?
Yeah, whether or not could it be IgA nephropathy?
IgA nephropathy.
Whether FSGS or even membranous proliferative MPGN.
Okay, wonderful, wonderful. So, anybody from Indonesia? Dr. Pringle, you are president, so maybe you can choose for us.
Yeah, Oriza will try to answer.
Okay, thank you. Oriza, to introduce yourself and then you. Yeah.
Good afternoon, Professor and colleagues. I'm Oriza from Indonesia. So maybe thank you for the invitation. This is an interesting case we have here. So maybe if I can conclude the problem list in this patient, I think this patient had nephrotic syndrome with the clinical is very clear with albuminuria is in nephrotic range is 12 grams and also had the edema anasarca and also, but I think the potential and also we can see the proliferative sign with the hematuric with the dysmorphic 50%. So I think I agree with the colleagues before. The potential cause is maybe because of cryoglobulinemic glomerulonephritis. With the differential diagnosis, maybe MPGN or membranous, it could be also.
unmute. Okay, for this case, the problem is a nephrotic with creeping of serum creatinine for a resident. So maybe we can list as RPGN with nephrotic and nephritis. And the patient also have a high blood pressure and equally for the both extremities, and also the patient have anemia and low complement. Yeah, low complement. So anybody want to try more? Because if too straight to like a IgA, so maybe for the first showcase, maybe it's not suitable. Anyone from Taiwan? Taiwan, I'm not quite sure. Chad, are you in? If not, Singapore, and anybody from Singapore or Australia, or maybe Somkanya from Canada, you want to try? The patient have only low C3, and normally cryoglobulinemia, they should have a low C4, lower C4 and low C3, but this is only low C3, low and normal C4. Anyone want to express or discuss more? Okay, maybe we will try with my country. Phumipon, Dr. Kampantong, do you have any fellow want to assess or show express some more or discuss some more this else? Dr. Kampantong?
I don't know. My fellow, please.
Are you ready?
Yeah.
Okay.
I'm fellow first year fellow from Bhumipon Adrenaline Hospital. My name is Suvit Muyajalatgun. In this case, I think the differential diagnosis I will approach to nephrotic syndrome. I think he got a RPGN with nephrotic feature. So I think that the differential diagnosis is immune complex or complement mediated glomerulonephritis. The differential diagnosis February glomerulonephritis or cryoglobulinemic vascular glomerulonephritis and C3 glomerulonephritis. Thank you.
So do you think this case is a primary? So first of all, we have the differential glomerular pattern. So do you think the pattern of glomerular of this case should be MPGN? Okay, we have choice. So which one do you think this is should be the most appropriate or suitable for this case? Between A, presentic, B, diffuse proliferative GN, C, mesangial proliferative GN, D, MPGN, or E, nephrotic with AKI with not yet defined the pattern. Okay, we're gonna go back. Oh, hi, Angela. Wonderful to have you here.
Hello.
Hello.
Hi. Hi. Thank you so much for talking to us.
Do you have anybody from Singaporean want to share or want to access or want to respond for this question?
Hello.
I'm not sure who's on. I've just joined.
Okay, doesn't
So
matter.
I'm not sure what's the question. Maybe you have to answer this question, Golf.
Okay, good.
Yeah.
So maybe go back to Surita.
Hello, yeah.
Okay.
I'm Joel from Selayang Hospital, Malaysia. The pattern of injury most likely will be D. D option will be membranoproliferative GN.
Okay.
Usually cryoglobulinemia will have a low C4, but in this case, I saw it's a low C3. It could be C3GN with maybe a rapidly progressive GN and a membranoproliferative MPGN pattern of injury.
Okay, good.
One of the differential.
How do you explain the cause of anemia if you think it's a C3GN?
Maybe TMA.
Oh, TMA, good. And how about the hepatitis? We have anti-Hep B core antibody positive. That is related to MPGN that you answer. Is a hepatitis related?
His Hep C is positive. You mentioned Hep B core is positive.
Yes, anti-Hep B core antibody positive. Hep B is
Yeah.
negative.
Most likely has a past infection of hepatitis B. But yeah, we would like to see the viral load of the Hep B.
Okay, so do you think is the number one is the C3 glomerulopathy and you with the MPGN pattern. Okay, good. So you're gonna read the slide, right? Okay. Dr. Jidesit, do you think that we're gonna show or we gonna display scan slide a little bit and let him to read?
I don't think we need to show the scan slides. I think that the images are all right.
Okay, we will show.
Because we have only 3 glomerular lines, so I think the images is very representative of the findings.
So I will guide. I will guide you through a kidney biopsy.
Golf, excuse me. Do you hear me?
Oh, hi, nice to talk to you, Sokanya from Canada, Calgary.
No, I'm in Edmonton actually. Anyway, I mean, like, I do agree that this pattern of injury, like they have like a very obvious pattern that's compatible with nephritis, at the end of the manifestation. But when you look at the onset of the manifestation, you see that the symptoms that this patient has, like all this peel edema or eyelid edema, like even though they have the hypertension, but it seems like they also have like the mechanism of the oncotic pressure. So I think anyway, we should aware that even though they have the patterns that would match with the creeping of GFR decline during the past few months, but they might have some nephrotic syndrome that would cause the chronic nephrotic syndrome, like that main mask by those nephritis. So I think that all those, and also with all those underlying disease or the age, we should think of other cause of secondary nephrotic syndrome that may be either underlying instead of just nephritis. So the other differential diagnosis I want to point out, more than all those proliferative lesion or maybe some deposition disease, because it can cause the chronic nephrotic syndrome and creeping creatinine at the end, and they might have those proliferative lesion on top, if possible. And it's just to mention it.
Yeah, so thank you for made an important point. Before we go to the pattern, so we have to make sure the patient define the syndrome first. So the patient have a nephrotic because huge high protein proteinuria and low serum albumin and general edema, foamy urine. So this is definite diagnosis for nephrotic syndrome. For nephritis, so the patient have creeping of serum creatinine and also high blood pressure. And also we have glomerular hematuria defined by dysmorphic red blood cell in your urine more than 50%, and some textbook maybe state in more than 80%. So we have the patient have nephrotic and creeping of serum creatinine, and be sure that the patient is not primary because patient have a low complement and also have anemia. So the pattern maybe be the most likely should be epigen, but maybe the other. And also, okay, we're gonna go to the slide. And who gonna be the first volunteer for read the slide? I think we're gonna show just only one scan slide for. When do you display scan slide, or did you display picture by picture?
I only have static pictures.
Okay. Yeah, okay. Scan slide, so we upload to the website, so you can go to that. And now we show the picture, so very easy to follow. Okay, who gonna be volunteer for read the slide? Olisa, do you want to try? Dr. Orisa, do you want to try? Okay, maybe not.
Dr. Monique mungkin.
Okay. Dr.
Maybe.
Bon, right?
Monique.
Monique, okay. Apologies that you mispronounce. Okay, Dr. Monique, please.
Okay, Doc. Hi all. I'll try, but correct me if I'm wrong. So I noticed that there are some glomerulus, but there's no crescent formation. And then we can see there is expansion in the matrix mesangial and also the endocapillary hypercellularity. And then we also seen injuries in the tubulointerstitials, and also in the arteries, they have the thickening of the walls, the vessel walls. But I think there is no vasculitis. And I thought the first probably some nodular, but I don't think it's a nodular glomerulosclerosis, but it's more likely
You should not go
membranoproliferative.
fast. You just slowly click the slide. Okay, sorry to interrupt. Sorry.
Yes. I only see the HNE stating from the slides, but yes, as I can see in this trichrome, I think it's more likely the endocapillary proliferative, I think. And yeah, I don't see any vasculitis or TMAs. Please correct me if I'm wrong. I think yeah, this is more likely endocapillary proliferation and no crescent formation. And there's a lot of atrophy in the tubular and also fibrosis in interstitial. Yeah, I think that's all probably. Thank you.
Do you have a silver stain, please?
See. So
this is nice.
Yes. So I think this is probably some double contour and also a lot of the endocapillary proliferation again, and yes, a lot of chronic damage already seen. Yeah. Thank you for the opportunity.
Anyone in the Zoom want to raise some more detail?
Sorry, do you have any images for PAS of the glomeruli? Sorry, I
Okay.
must have missed them.
We'll go back. PAS. Yeah,
So,
this
yeah,
one.
this sort of gives sort of an impression of lobular accentuation, and you can see
good.
quite a bit of mesangial matrix expansion, and you see this rounded structures all over the place. And yeah, if sorry, could I have a look at the silver, please?
So for the glomerular pattern for this
Yeah.
case, gonna
So
be
yeah, this looks very much like a mesangial proliferative pattern, and it sort of fits because you sort of see in the silver stain here, you got some really nice double contouring to maybe around 8 o'clock. That's the prettiest one, but I'm sure there's better ones elsewhere as well. And you also see an element of endocapillary, a diffuse and global endocapillary hypercellularity that is accompanied by mesangial hypercellularity and matrix expansion. So it's giving this nodular kind of feel to it, which sort of resembles a little bit of diabetes as well. But overall, I think the architecture is that of a membranous proliferative pattern.
okay.
With a little bit of chronicity in the background.
So fit for MPGN pattern.
It does.
And
It does.
if you you select MPGN, so what is your differential diagnosis, and do you think what category that the patterns go to? Because Dr. Sandy said, oh, when you have MPGN patterns, so it go to 4 or 5 category: polyclonal, monoclonal.
Well, yeah, I mean, I was
Yeah.
going to ask if you were going to show any immunofluorescence at this point, because which category it falls into would depend. But based on the clinical history and investigations, I think the things that really stood out to me, I'm sorry if I missed anything beforehand. One point is that he has hypertension and chronic, you can get chronic TMA, which can look like this with long-standing hypertension, sure. So that's one issue. So then I think he has hepatitis infection as well, viral hepatitis, so that can contribute to this as well. The other thing was he has complement abnormalities, so I think that needs to be looked into. Sorry, I can't remember off the top of my head anything else, because I'm sort of like going in and out of this presentation.
Well, wonderful. So maybe you're gonna look at the other structure of the kidney tissue, right? You look at the vessel, tubular in the area.
I don't think I saw there were any pictures of the vessels. I think there was probably one
go
low image one. One low mag one.
Yeah.
So yeah, this is I think a medium size or maybe a smallish artery. I think it's intralobular, and you can see significant intimal fibrointimal thickening, and you have a little bit of myxoid degeneration there. If there was an EVG, I'd like to look for any duplications of the internal elastic lamina as well, but there's no element of vasculitis or fibrinoid necrosis that I could see here. I wonder if there's any pictures of any small arteries, arterial, sorry.
Do you have
any evidence of arterial halanosis? No, it's not
maybe one just like next to the artery, but maybe two.
No, I mean, I was looking for any possible arterial halanosis there, or maybe even like concentric hyperplasia that might indicate accelerated hypertension given his BP, that his blood pressure is also.
Any more picture?
No TMA changes either that I could see here. I mean, so far.
I think it's all the pictures that we have taken of the blood vessels.
Okay, Dr. Gilles, before we go to immunofluorescence, so you have any comments on the slide?
Oh yeah, I agree with the pathology reading. Is there anyone here a renal pathologist here? Any renal pathologist?
I'm just a normal pathologist, so.
Oh, okay.
But I do read quite a bit of.
Very. I agree with everything that you read.
Okay, thank you.
There's one more thing. If you look closely at the H&E, you might see that the mesangium is not staining as intensely as other areas, and if you go to the silver stain, it has lost this silver affinity or angiophilicity, and
you wouldn't have a Congo red for me, would you?
You have to move to silver stain when you talk of silver staining. because some of the
I don't have
nephrotic
control of the
may be
PowerPoint slide, so when you have to move yeah. So the mesangium should just stain black, like a normal mesangium, but this has lost a lot of the silver affinity. It means that there is some foreign substance that is not the normal mesangial matrix that is being deposited in the mesangium. And if you go to the trichrome stain, that would be like the biggest clue, because normally the mesangium would stain blue, but this one is like red all over. So it's telling us that there is some foreign substance that is being deposited in the mesangium, and we have to figure out what it is. And actually, if you look at the pathology textbook, there will be like a table with differential diagnoses, and there is only one disease that does this.
Oh, this
All
is
right.
rare.
There you go.
I hope we have good EM pictures.
So we should not go to this slide because we should have immunofluorescence. Okay, but okay, you this is fine. All right. So what next? Can you just tell the nephrologist or teach the nephrologist to look at the tubular interstitial area and vessel? Maybe you want to highlight more, or you just agree on the whole set with the other tissue?
I can. That's actually the two distals are everything we have, because the original tissue is much larger than this, but we already throw away all the slides. So this is the recut. So this is all the tissue that there's left.
Do you think that the deposit is on the other tissue beside of the glomeruli, or just
the other piece of tissue is the
fine?
It's not very informative. So we only have like a patch of tubules with acute tubular injuries. You can see from low power that the tubules look dilated, and there's flattening of the epithelial cells. If you go to PAS, you'll see that there is loss of the rush border that would indicate acute tubular injury. And we have severe vascular disease. That's the PAS. These cells have lost all their rush borders, and that's the renal medulla. There's a little bit interstitial inflammation there, but I don't think we can make anything out of that. Okay, not a lot to say apart from NPGN pattern and acute tubular injury and severe vascular disease.
Okay, Win, do you please go to the immunofluorescence. Because we actually don't capture the picture at that time, so we have only the report.
I think we actually what we do is, for some pathologists, this is from before I became a pathologist, so this is from like 10 years ago. If it's negative, sometimes we don't take pictures of it. So these are probably essentially negative, so there is no I have pictures.
Okay, before we answer the case, so immunofluorescence help us to
Exclude some of the exclude some of the.
So we're gonna exclude polyclonal, monoclonal, right? And now to this, how about complement dysregulation? Do you anybody think it's C3?
Do you have a paraffin IF perhaps, or any immunohistochemistry that complements this what looks like a direct fresh tissue IF study?
No, we don't have that, unfortunately. But it would be great to do a paraffin IF to unmask some of the, if there were like deposits there. But from what we have, the C3 is actually staining along the peritubular capillary. Right? It says granular peritubular staining. It's not in the glomeruli.
Okay.
So I assume that the glomeruli are essentially negative for the stains.
Yeah, for this case, it's negative for the whole set of the glomeruli. So it's gonna fall to the category of chronic TMA, right? Or the other. So we go to EM because
well, if you consider the MPGen pattern, then you might consider TMA, but look at the mesangium that is expanded by those material that are silver negative. There must be something deposited in there, right? Maybe do you have a Congo red?
Yeah, I was asking for a Congo red if you had one. Oh, okay then.
Okay, negative. That negative.
And polar negative as well. Okay, we go to the EM. I think this is maybe you just highlight because highlight the picture.
Yeah, got like 15 minutes left. So this is a low power of the glomerulus, and you can see the electron dense deposits, mostly in the mesangium here and there. And we go to higher magnification. You can see like a vague fibrillary structures, substructures in these deposits. Fortunately, we didn't measure the size.
Actually, at that time we measure, it's about 30 to 40 nanometer.
30 or 30?
30.
30, 0?
30, exactly.
It's kind of big. Okay. I think we have only two pictures, two EM pictures.
Oh. Sorry, doctor, you don't have any sort of like a fibronectin, DNAJB9 kind of immunohistochemistry pictures
of course,
to share with us?
we have, yeah.
We didn't do DNAJB9. I think we don't have DNAJB9 back then.
Oh, this is a case from a decade ago. So at that time, we don't know this. This possibility,
right?
Yeah. But we did stain the fibronectin, as shown here.
It's a little, I think it's a little underwhelming. I mean, it's staining the peripheral capillary loops. It's not staining the mesangium at all. But,
sorry, the fibrils were in the mesangium, weren't they just now? Sorry, just in case I got it wrong.
Yeah, they were mainly in the mesangium, and the light microscopy also suggests that most of the deposits are in the mesangium.
You're right. Normally, fibronectin have two forms. It's a serum form and tissue form. At that time we have only one form, antibody. So that's why it's not frankly staining in the mesangium area. But actually, okay, for the tubular initial area and the vessel is negative for immunohistochemistry. So maybe we can, by the spatial staining, electron microscopy and fibronectin immunohistochemistry. So maybe we're gonna conclude case as a fibronectin glomerulopathy.
Okay, maybe consistent with the fibronectin. I have to leave for now. I'm sorry, I couldn't stay until the end. I'm on a frozen section call, and the specimen just arrived. So, thank you for allowing me to
Good
join
if
this
you can
wonderful,
dig more
conference.
deeper, because it's good that we have the frozen. No, we don't have frozen section. We have formalin section, so we can do further, and maybe we can do mass spectro.
Yeah, mass spectrometry would be great. I mean, I'm on call. The surgeon just sent me a tissue, so I have to go and do an intraoperative consultation. So I have to leave now. So thank you, everyone, and have a good day. The rest of the
Thank you for your time, your good and helpful information and share your opinion. Okay, when you go, you have any more to teach us?
Okay, so after the patient was discharged from the hospital,
to the fibronectin.
I'm sorry, Professor Thaleungsak, did you mention anything? I couldn't hear.
No, go ahead.
Okay, so the outcomes after discharge, he was controlling the blood pressure with antihypertensive medications, and the GFR went down progressively 2 months following that, and eventually the patient died from myocardial infarction at another hospital. So we didn't see the patients after 2 months of follow-up.
So the patient end up pass away by the cardiologic cause. So, and you have any review for highlight?
Just a short review for fibronectin glomerulopathy. So it is a rare inherited autosomal glomerular disease, and it usually presents in the 2nd to 4th decade of a year of life, and presents with nephrotic range proteinuria, microscopic hematuria, and hypertension without any systematic manifestations. The pathogenesis was still unclear, but we believe that they have an abnormal mutation in fibronectin gene FN1 on chromosome 2q34, and it will cause abnormal production of fibronectin variant that cannot be cleared by the kidney, and will cause the fibronectin accumulation in the glomeruli. And there may be also defect in the catabolism of fibronectin, and there is no specific treatment for this disease, only supportive care to control the proteinuria and hypertension using ACE inhibitors. And the prognosis of fibronectin glomerulopathy is variable. 25% of the patients progress to ESKD within 15 to 20 years of disease onset, and they may recur after kidney transplant.
So any relation or any link with the energy drinking, because you mentioned that the patient abuse of the energy drink for decade or 10, 15 years. And
so I tried to look up on the literature, but couldn't find any links or association between the acquired form of fibronectin glomerulopathy with any kind of substance or drug
abuse. Okay. Any comment or any question from the floor or from the Zoom? So this case is a decade ago, and we have a paraffin section. So and Dr. Jidesit want to help us to dig it deeper by mass spec, and also he may want to stain with the fibronectin again, because at that time we have only one antibody. So maybe we will dig deeper and we will progress to your guy with in the WhatsApp. Anyone want to comment or want to share opinions on the fibronectin commodopathy or the other case, other idea? Hopefully not too complicated case, but it so actually from the Santry that you see, do you have a diagram of Dr. Santry differential diagnosis for the epigen? Win, do you have any slide on that?
I just have
Epigen?
this one table.
Okay. Normally we Dr. Santry classify epigen according to immunofluorescence to polyclonal. If we have positive IG, many immunoglobulin, and then monoclonal and complement dysregulation and negative all, and he differentiate only chronic TMA transplant coagulopathy. So fibronectin for this case fall to the category of negative immunofluorescence. And hopefully after we get the whole set of workup, so we gonna write the case report. Okay. Sunita, do you want to any comment before we close? You have to close the session
Yes.
after.
I realized we're coming to the end of our time. I think that was a very interesting case. I just want to know whether the incidence of the cryoglobulin, is that well known, like a false positive kind of finding or something with your disease?
Well, in Thailand, it's about 1% of the kidney biopsy, but for MPGN, we maybe 20 to 30%.
Maybe a false positive cryoglobulin, is that what you're saying?
Yes.
Right. Okay, so that's a red herring, and so was the energy drinks were also a red herring in the story, but a very interesting story. I wonder, just in the remaining time, can perhaps we quickly get a photo gallery shot, Gal, so we can.
Oh, good. So please open
Your cameras, yeah, please.
camera.
Yeah.
Camera.
Is it possible?
Please.
Yes. Oh, you have to stop sharing slide, Gal. Then we can
Yeah.
get a photo.
Okay, we stop right now. Thank you.
Excellent. Thank you.
So we're gonna see beautiful face from our colleague in the region. So that you have to change from the panda picture to the.
Yes, I will change from panda. I didn't realize it was panda there. Oh dear, how embarrassing. Hopefully it's cute. It's cute.
Yeah, I know it's cute, but okay. Good.
Yeah, I thought you wanted to remain
Oh,
incognito.
it's the long time no see.
Hi, girl.
Is everybody there? Can you see?
Oh, you have a big group, Sunita. Oh, really large.
Okay.
But we can't see everybody else.
You have to screenshot a few
in the
pages. There's
nighttime.
120 participants.
I think it's 2 a.m. right in your local time.
It's midnight.
Midnight. Okay. This is a gentleman, Dr. Win, who was the presenter of us today.
Thank you very much, Dr. Win. Well done.
Thank you.
Okay. So, Sunita, next time, do you say something for the next seminar?
Control F4.
So next time we're gonna have a PD case discussion, right, Sunita? So the next take picture. So next time gonna be PD case discussion on which day, Sunita? You recall?
I think maybe next month, but we said it will be the last week, right?
Last week on Tuesday,
Last week on Tuesday.
yeah, 1 p.m. for Malaysia and Indonesia, 2 p.m. for Singapore.
Yeah, I'm just wondering which team might want to take next round. Because
Want
we
to be
have
the
Thailand
next
and
round for
Malaysia.
PD?
We will ask Singapore.
Okay, Marjorie, okay. If Marjorie declines, so we have the alternative. Do we? Okay.
Thank you so
Next
much.
up will be PD.
Very nice presentation. Your presentation.
If Singapore decline, gonna be Indonesia. The Pringle, are you okay to present PD case?
It's talking to me.
Yes.
Next time gonna be PD. Next month.
Next one is PD. Yeah.
Okay.
Yeah.
Thank you,
We will.
everybody, and
Thank you. Bye-bye.
terima kasih.
Okay. Okay, we are good. We are good. Okay,
再见，
bye-bye.
再见。
Thank you. Sawadika.
Thank you, Prof.